Hello dear viewers, today in this video I will be discussing updates on use of intravenous iodinated contrast in patients with acute kidney injury and chronic kidney disease based on most recent data. I am Dr. Sunil Garg from Essentials of Acute Care. As we always do serum creatinine before any contrast CT scan, what is update on this? Recent updates and recommendations regarding intravenous contrast and acute kidney injury emphasize that iodinated contrast media can be safely used in patients with mild to moderate renal dysfunction with an eGFR of 30 ml per minute or greater. For patients with severe renal dysfunction means when eGFR is less than 30 ml, the decision to proceed with contrast imaging should be individualized. So what physician should do? Proceed with contrast imaging studies in any patient who has eGFR more than 30 ml per minute as risk is low in these patients. If eGFR is less than 30 ml per minute, assess the necessity of imaging versus risk of acute kidney injury. If imaging is of emergency nature and will provide diagnostic therapeutic implication, proceed with imaging irrespective of eGFR as a measured approach. Discuss the benefit and risk of intravenous contrast. Provide preventive measures before contrast administration to all patients if eGFR is 30 ml or less. Provide preventive measures if eGFR is between 30 and 45 ml when there is presence of high risk factor in a patient. Though various definitions of contrast-induced acute kidney injury are available, the one which is given by Kidney Disease Improving Global Outcomes entails an absolute increase of 26.5 micromole per liter or 0.3 mg per deciliter in serum creatinine compared to baseline within 48 hours after intravascular administration of iodine contrast medium, or a relative increase of more than 50% within 7 days, or a urine output of less than 0.5 ml per kg per hour for 6 hours without the influence of factors such as surgery or nephrotoxic drug. It remains challenging to identify the contribution of contrast leading to kidney injury in a patient who presents with occult or abdominal sepsis, and contrast is given to identify the source. In such situation, the better terminology is contrast associated rather than contrast induced. The risk of developing contrast induced AKI or CI-AKI depends on factors related to the patient, contrast, and the medications. Age 75 or above is suspected to be a risk factor, but correlation between age and CI-AKI is not clear. The presence of chronic kidney disease stage 4 and 5 is considered a risk factor for contrast-induced AKI. Diabetes is a common risk factor for CI-AKI, but it is not clear whether diabetes is an independent risk factor. Some studies have found that serum uric acid levels more than 8 may be related to the occurrence of CI-AKI. Regarding the type of contrast agent, the risk of nephropathy is high with the ionic high osmolar contrast than non-ionic low or iso-osmolar agents. The nephrotoxic effect of contrast may be proportional to the dosage used, and the use of higher dosage is associated with an increase in the incidence. Repeated administration within a short interval of 48 to 72 hours has been shown to increase the risk. There are also suggestions, though not confirmed, that arterial injection of contrast with first pass renal exposure has a higher risk of contrast induced AKI compared to intravenous injection. The risk of contrast-induced AKI significantly increased if patient is receiving non-selective NSAID, selective COX-2 inhibitor, antimicrobial and chemotherapeutic agents with nephrotoxic potential. Metformin use combined with contrast has a potential risk of lactic acidosis but not increased risk of CI-AKI. While contrast-associated AKI is a concern, minimizing contrast volume is crucial particularly in high-risk patients. But how we calculate contrast volume which is safe for a patient? The volume of contrast to creatinine clearance ratio is an index recommended to quantify the contrast volume administered during interventional procedure to minimize the risk of acute kidney injury, especially in patients with the baseline impaired renal function and other risk factors for AKI. A higher ratio indicates a greater volume of contrast relative to kidney function, potentially increasing the risk of AKI. The ratio is calculated by dividing the volume of contrast administered in ml by the patient's creatinine clearance in ml per minute. It is suggested to keep this ratio below 3, preferably below 2. So if patient has creatinine clearance of 50 ml per minute, then it is suggested to keep contrast volume below 150 ml, preferably below 100 ml. The preventive measures for contrast-induced AKI include adequate hydration, typically with normal saline is a cornerstone of prevention, starting before and continuing after contrast administration. It is the only proven effective preventive strategies as opposed to other pharmacological intervention, none of which is proven effective. For contrast CT scan, the suggested protocol for inpatient include 0.9% normal saline at 100 ml per hour intravenously beginning 6 to 12 hours prior to contrast administration and continuing 4 to 12 hours afterwards, and for outpatient 0.9% normal saline 500 ml IV bolus prior to contrast administration. Discontinuing non-essential nephrotoxic medications may be beneficial if feasible. Strategy to minimize contrast volume: employing imaging techniques which does not require contrast like echocardiography instead of ventriculography, or using lower risk contrast like gadolinium in MRI in some patients with kidney disease may be considered. So to summarize, contrast administration does not need to be withheld in patients with mild to moderate renal dysfunction, means when the eGFR is 30 ml or more. For patients with severe renal dysfunction, means when eGFR is less than 30 ml per minute, the decision to proceed with contrast imaging should be individualized. Contrast imaging should not be withheld if GFR is below 30 ml and the perceived benefit to the patient in the opinion of physician based on potential harm from contrast with the risk of delayed or inaccurate diagnosis justified this administration provided all possible preventive measures are in place. If patient has high risk factor for CI-AKI, preventive measures should be undertaken if eGFR is below 45 ml. Essentially, contrast administration should not be withheld if it is medically necessary. Do you consider this information is relevant and important to your practice? If so, please provide your feedback and do not forget to subscribe to this channel. If you have any questions, please write them down in comment section. See you in my next video. Till then, bye and take care.